4 years child have a car accident and the GCS is 5, heart rate is 52 and RR is 8. What to do? A CPR, B MV. What is MV? I don't know. Mechanical ventilation. MV is mechanical ventilation. So now your choice depends on, if heart rate is 52, it is bradycardia. If heart rate is 52, bradycardia. So as per the bradycardia algorithm, with cardiopulmonary compromise, that means you're not getting good pulse, and the child is bradycardic, pulse is very weak, you can start CPR and then intubate. But suppose if the case is heart rate is 52 with increased intracranial pressure. How do you know increased intracranial pressure? That is Cushing's triad. Cushing's triad, that means increased blood pressure, but bradycardia, reduced pulse, and reduced respiration, bradypnea, reduced respiration. So reduced respiration. So here respiratory rate is 8, bradycardia, but if you have increased BP, it will go with increased intracranial pressure. In such case, what you will do is, if BP is very high with very good pulse, then no need to do CPR. Intubation should be done. Rapid sequence intubation should be done, and brief hyperventilation. Rapid sequence intubation and brief hyperventilation. No need to do CPR. No need to do CPR. So it depends whether you get a good pulse, and if the child is bradycardic with a good pulse and high blood pressure, then it is going with increased ICP. No need of CPR. You will just intubate with rapid sequence intubation. If the child is bradycardic and bradypneic with weak pulse, that means he needs CPR. So the same question in naja notes. 4 years old child have a car accident of GCS 5, heart rate 52, respiratory rate 8. What to do? So you will do CPR. But again, heart rate 52 can be bradycardia. According to the bradycardia algorithm with cardiopulmonary compromise, start CPR and then intubate. Astaghfirullah. If heart rate 52 with features of increased ICP, that is BP very high with very good pulse, intubate with rapid sequence intubation and brief hyperventilation, no CPR. So, this one more thing we'll read about the drowning now. Least poor prognosis in a child with near drowning. When do you see least or poor prognosis in a child with near drowning? Absent brainstem reflexes more than 24 hours. More than 24 hours absent brainstem. Absence purposeful movement more than 24 hours. Absence brainstem reflexes more than 24 hours. Absent purposeful movements more than 24 hours. Core body temperature less than 32 immediately after immersion. Immediately after immersion, if you see core body temperature less than 32. So let's go to the next question. Before that, so I want to let you know what are the brainstem reflexes and how is the testing. Brainstem reflex testing. Brainstem reflexes are pupillary light reflex. Here the afferent nerve 2, that is the cranial nerve 2, The Edinger-Westphal nucleus in the midbrain is involved in brainstem nuclei, and the afferent nerve is cranial nerve 3. Then corneal reflex, oculovestibular reflex, pain stimulus, gag reflex, cough reflex, all these are the brainstem reflexes. So remember some brainstem reflexes: pupillary light reflex, corneal reflex, oculovestibular reflex, pain stimulus, gag reflex, and cough reflex. So next question, case of VSD, 9 months old, 5 kg, precardium protruding right, precardium is protruding to the right, left precardium is protruding, precardium is protruding, right and left heave. That means both the ventricles are hypertrophied usually. Second, palpable sound with 93% saturation in the room air. And now he is on diuretic, digitalis, diuretic, digitalis, captopril. Most next step is to do immediate catheterization and surgery. Yeah, because this child is VSD. He is 9 months old already, 5 kg, and the precardium is protruding, and there is heave. Heave means there is ventricular hypertrophy. So if the left ventricular heave means there is ventricular hypertrophy. Then there is second palpable sound, 93% saturation in the REM air. He's already on diuretic digitalis and captopril. It will be immediate catheterization and surgery. The same question now. Case of VSD, 9 months, 5 kg, precardium protruding, right and left heave. Second palpable sound with 93% saturation at room air. Now he is on diuretic digitalis captopril. Most next step is to do wait for age 2 to 3 year and do surgery. Wait for age 2 years as spontaneous closure may occur. Immediate catheterization and surgery. It too late as pulmonary hypertension already occur. So the answer is immediate catheterization and surgery. So the next question, of the following manifestations of acute rheumatic fever, which is not relieved by salicylate or steroid therapy? Okay, so acute rheumatic fever, the following manifestations, that is carditis, arthritis, fever, chorea, and abdominal pain, which is not relieved by salicylate or steroid therapy, is the chorea. So administration of salicylates and steroids can relieve, inflammatory manifestations of acute rheumatic fever. Steroids are used to treat affected children who have carditis with an enlarged heart. So carditis with an enlarged heart, we give steroids. Neither salicylates nor corticosteroids have a therapeutic effect on chorea, but barbiturates and chlorpromazine may be helpful. So for Korea, there is, if they ask about of the following manifestations of acute rheumatic fever, which is not relieved by salicylate or steroid therapy, the answer is the Korea. Other inflammatory manifestations like carditis with an enlarged heart will improve with steroids, but neither salicylates nor corticosteroids have a therapeutic effect on chorea. But what do you use for chorea? You will use barbiturates and chlorpromazine. So, a similar question of the following manifestations of acute rheumatic fever, which is not relieved by salicylate or steroid therapy, that is chorea. Same thing, administration of salicylates and steroids can relieve inflammatory manifestations of acute rheumatic fever. Steroids are used to treat affected children who have carditis with an enlarged heart. Neither salicylates nor corticosteroids have therapeutic effect on chorea, but barbiturates and chlorpromazine may be helpful. So remember these two, barbiturates and chlorpromazine, may be helpful for the chorea. Next question, ECG surgical correction of TGA. So if you, after surgical correction of transposition of great arteries, what do you see in ECG? Sick sinus syndrome. ECG after surgical correction of TGA, you see sick sinus syndrome. Same, ECG after surgical correction of TGA, you see sick sinus syndrome, but let's see what is it. Sick sinus syndrome is a group of heart rhythm problems due to problems of sinus node. Okay, sick sinus syndrome is a group of heart rhythm problems due to problems with sinus node, such as the heartbeat rate is too slow, called sinus bradycardia. The heartbeat pauses or stops, called sinus pauses or sinus arrest. Episodes of fast heart rate. So, sick sinus syndrome is basically sinus node dysfunction. Is a group of it is a group of heart rhythm problems due to problems of the sinus node. So it can be heartbeat is too slow, that is bradycardia, or it can be heartbeat very fast, that is tachycardia, or heart can pause for some time or stop for some time. This is called sinus pause or sinus arrest. What is the most common cause of coarctation of aorta? Is it a viral infection? I don't think so. Drug toxicity, prematurity, chromosome abnormality. So what is the most common cause of coarctation of aorta? Chromosome abnormality. And we all know that we see this coarctation of aorta common in Turner's syndrome. Turner's syndrome, which is X0, that is only one X chromosome. So what is the most common cause of coarctation of aorta? Is the chromosomal abnormality. Next question. Child 6 years old present to ER with heart rate 40. RR 33. Not gasping. Hypotensive. Now here we have two factors. Bradycardia, hypotensive. Capillary refill more than 3. That means delayed. Cold extremities. Diagnosis. Cardiorespiratory failure, respiratory failure. See, he is RR33, not gasping. That means he's not respiratory failure. He can be shock, but late phase of shock because there is bradycardia. Tachycardia will be there. Tachycardia and hypotension in shock. Heart failure. So he's writing cardiorespiratory failure. Same question. Child 6 years old, present to ER with heart rate 40, RR 33, not gasping, hypotensive, sciatic cold extremities, diagnosis, cardiorespiratory failure. Next question, a case of blood pressure 60 by 30, RR respiratory rate 30, heart rate 40. 60 by 30, definitely it's a lower side of blood pressure. Heart rate, there is bradycardia and he's gasping. The cause is when he's gasping, the gasping heart rate is low and blood pressure is also low. That means he's in cardiopulmonary arrest. Usually we know that we are, if in the bradycardia algorithm of children, if the child is bradycardic and no pulse is palpable and RR is very less gasping for air, he is in arrest. Okay, and also BP is on the lower side. So BP 60 by 30, respiratory rate is 30, but he is gasping for air. It's written here 30, but he is gasping for air and heart rate is 40. So this is cardiopulmonary arrest. Maybe this RR will be less here. What they have given is wrong. Let's see here. The same question. BP 60 by 30, RR 30, heart rate 40, gasping for air. Cardiopulmonary arrest. Okay. 9 years old child with pigeon chest and recurred chest troubles easily treated. He is developing dyspnea with exertion on auscultation, nothing abnormal heard on the chest. So 9 years old child has a pigeon chest and he has recurrent chest troubles. What are the chest troubles you see is which are chest troubles which are easily treated, and he is developing dyspnea with exertion. Means if he does any exercise, he has dyspnea. On auscultation, nothing abnormal heard, means you're not hearing any murmur or something. Most probably this is dilated cardiomyopathy. Means the clue here for you is dyspnea with exertion and there is no murmur or anything on auscultation. One more thing, do you see pigeon chest commonly in dilated cardiomyopathy? That we have to check. Okay. So the important clues here is dyspnea on exertion and nothing you're hearing on auscultation. So this will make you choose dilated cardiomyopathy. So here it's written Marfan's syndrome. Maybe this is a child of Marfan's syndrome. Two things here. 9 years old, pigeon chest, recurrent chest troubles, but can be treated easily. There's dyspnea on exertion, nothing on auscultation, dilated cardiomyopathy. Here it is written, maybe this is a child of Marfan syndrome. Patient kicked out of the car, brought to hospital, intubated and ventilated. High blood pressure, bradycardia. See, high blood pressure and bradycardia is taking us towards raised ICT. Now, this child is ventilated. This child is ventilated, but he has high blood pressure. Bradycardia, and his GCS is 5. And his GCS is 5. What to give? Mannitol, cerebral edema. They are suspecting cerebral edema in this patient. Cushing's triad, that is bradycardia, hypertension, and hyperventilation, bradycardia, hypertension, and hyperventilation. That means there is increased ICT. So we'll do cerebral edema. There is cerebral edema. So what is the treatment for cerebral edema? Is the mannitol. Mannitol is the treatment for cerebral edema. One minute. So case of aortic stenosis, athlete's body. I don't know what they are telling here. SVT in a hemodynamically stable patient, start vagal maneuver, ice packs to the face attached to a lead ECG. A case of aortic stenosis, athlete's body. I don't know. Yes, in the question of VSD, loud second heart sound means pulmonary hypertension, but still, but I think still there is no right ventricular hypertrophy and there is no reversal of strength, shunt, and the child is not cyanosis. So still we have means Eisenmenger syndrome is not developed, so still we have a chance to do surgery. Case of aortic stenosis, what is this athlete's body? I don't know what he has told about it. I don't know really. Okay, in drowning child, which is true. Sorry, in drowning child, which is true. Hypothermia is most observed in a child. No hypoxic insult. No relation between period of drowning and sequences. Laryngospasm. The best way to measure core body temperature is by rectal thermometer, not by tympanic membrane root hook. This we have to remember. How do you develop the best way to measure core body temperature is by rectal temperature, not by tympanic. This is one thing we have to remember. And in a drowning child, laryngospasm is common. Laryngospasm is common, and this may be the cause for hypoxia. But if this option is not given, choose the option of hypothermia is most observed in a child. So drowning child laryngospasm is the most common, and also if this answer is not there, choose hypothermia. Next question. Child with vomiting and diarrhea, weak peripheral pulsation. So that means dehydrated, vomiting, diarrhea, weak peripheral pulsation.